Boa tarde a todos. Queria parabenizar os organizadores, Henrique Lima, pela excelência do evento. Vamos abrir agora uma mesa de descalonamento do tratamento cirúrgico do câncer de mama.
Greetings. We'll start this panel on the surgical de-escalation of surgical treatment. The role of axillary ultrasound, de-escalonate biopsy of the sentinel lymph node are the scales. To select patients for the neoadjuvant treatment, we have Giuliano Mendes Duarte. Giuliani is a breast surgeon of the Unicamp Women's Hospital, mastologist at the Famine Clinic in Campinas, has a PhD and is a PhD student through the Unicamp. The second talk will have Dr. Thorsten Kühn. Are you comfortable in omitting axillary staging for T1 and 0 tumors? Considerations and so Dr. Kühn is the chair of the breast, member of the German Committee of Guidelines for Breast Surgery through the University of Germany. The third speaker, conservative surgery of the breast in local relapse, given by Dr. Alastair Thompson, who is responsible for clinical trials in breast cancer, DCIS, and molecular changes. And finally, we'll have a re-irradiation in the reapproach of conservative surgery and the relapse of breast cancer, given by Lilian Faroni, who's a radio-oncologist of the DOOR network and has a master's and PhD in oncology.
Uma boa tarde a todos. Queria agradecer a comissão organizadora por esse convite. E o tema que eu vim falar para vocês hoje é o papel do ultrassom axilar e intervencionismo em descalonar.
The role of axillary ultrasound and interventionism to de-escalate or escalate, selecting patients for neoadjuvant treatment. The only disclosure I have is that I'm the main researcher of the Venus study. I have no other disclosure. To introduce this presentation, first thing I'd like to say is that we will talk during my presentation, I'll talk only about patients with initial tumors, T1, 2, and clinically negative axilla. It makes no sense to think about ultrasound in an exam in which the patient has an inflammatory tumor, T4, with clearly positive axillary nodes, because you know the palpation, axillary palpation can get up to 40 to 53% of false negatives, showing that there is disease in that clinically negative axilla. And what is the role of ultrasound in these settings? What can it add? Well, it can show more disease that is clinically negative. The main function of ultrasound in a negative axilla is that it may select patients that have negative axilla or those who are clinically not very much involved. The axilla, the possibility of not having any disease pathology is high. There's the possibility of having a low quantity disease, and it is possible to have large disease. And small quantity disease in an axilla or negative axilla, throughout all the randomized trials that compared surgery with axillary surgery, have shown that to leave residual disease in the axilla, it has no impact on survival nor an axillary relapse rate, which are extremely low. Since studies with negative sentinel lymph node, those studies with positive sentinel lymph nodes, and the higher the degree of positiveness, the higher the risk of having disease in that axilla, although in the randomization it showed no reduction in survival. And having said that, there are some trials that came to give us the possibility of omitting the sentinel lymph node using ultrasound. The first study presented with the data presented in recent years, which was the publication Sangali, was the sound trial, controlled, multicentric, including women with breast cancer smaller than 1 and 2 centimeters with negative axilla upon ultrasound found
um
them
linfonodo
clinically or
positivo,
that had a
com um
positive
PAF
lymph
negativo
node
que iam ser
with
submetidos à
negative
cirurgia conservadora
fine needle
mais radioterapia.
aspiration
Elas foram
planned
randomizadas para fazer o
for
sentinela ou
conservative
somente
surgery plus
acompanhar essa
radiotherapy.
axila.
They were randomized for
Esse estudo
sentinel
começou em
node or
2012
just the
e eu
axilla
quero
study
fazer uma
started in
menção aqui ao Dr.
2012.
Veronese,
I'd
que
like
foi
to
um dos
mention here Dr.
idealizadores
Veronese,
desse
who
estudo,
was one of
e
the
os
creators of
resultados
this study,
apresentados depois de
and
um
their
segmento
results
de
presented
5,8
after
anos
a 5.8-year
mostraram que
follow-up
em todos os
showed that
desfechos
in all the
determinados,
outcomes
sendo o primeiro, o primário,
established,
né,
the
a
first was
sobrevida livre de
primary
doença à distância, secundários de
disease-free
sobrevida livre de doença
survival,
e sobrevida global, a
distance
realização
secondary,
da
overall
não cirurgia na
survival,
axila
free
não
of the
foi
disease,
inferior
and
à
not
realização do
operating the
linfonodo
axilla
sentinela.
was
Então,
not
hoje, o
inferior
ultrassom
to
se torna
doing
muito
the
importante no
sentinel
sentido
lymph node.
de
Today,
selecionar
ultrasound is
mulheres
very
que
important
possam
to select
não
those women
realizar a
that
biópsia do
may
linfonodo
not
sentinela, caso esse
undergo a
linfonodo
lymph node
sentinela seja
sentinel
negativo e
biopsy
tenham
if
tumores
the
iniciais.
sentinel lymph node is
Esse
negative
estudo,
and have
na
small
conclusão do
initial
estudo, eles
disease. Now, the
acabam sendo um
study
pouco
in their
mais
conclusion,
conservador,
they end
no
up being
sentido
more
de
conservative
ter essa
in
orientação
this
somente para
direction.
aquelas
There was
tumores
this
luminais e pacientes mais
guidance only
idosos,
for luminal
porque
tumors in
uma
elderly
das dúvidas e
patients because
limitações
one
que
of the
aconteceram
questions, one of the
depois dos
limitations
resultados do
that
estudo
happened
SALT foi
after
que eles
the
incluíram
studies
poucas
of the
pacientes
sound
jovens,
trial
pacientes
is that
triplo
they
negativos e
included
HER2 também
very
foram
few young
poucos,
patients,
né? O
very few
recrutamento
triple
foi
negative and
pouco
HER2
aquém
patients, so
nesses dois
recruitment
cenários.
was
E também não
short of
permitiram
what it should
tumores
have been,
T2,
and
pacientes
they
que eram
did not allow
mastectomizadas,
T2
que eram
tumors,
submetidas à neoadjuvância,
mastectomized patients,
e talvez
patients
por
submitted
isso
to neoadjuvant treatment, and maybe
essa
that is
conclusão
why
um pouco mais
they
conservadora.
had this
Entretanto, hoje a
conservative
gente tem no
conclusion.
mundo
However,
outros
today we
estudos
have in the world
randomizados em
other
andamento que estão
randomized
avaliando a
trials,
omissão do
ongoing
linfonodo
trials,
sentinela nesse
assessing
cenário de
the
axila
sentinel lymph
negativo,
node
clinicamente
omission
ao
in
ultrassom.
this clinically negative
Um deles é o
axilla,
estudo Ensino, que
or
ampliou um pouco mais
axilla
o
is negative
critério
to
de
the
inclusão
ultrasound.
do estudo
And
SOUND,
this broadened a little
permitindo
bit
até
the inclusion
T2,
criteria, the
estudo
sound
RUG,
study,
que além do T2
allowing
permitiram
T2, well, the
pacientes que iam ser
INSEMA,
submetidos
the
à
BUG
neoadjuvância,
included patients
um estudo
submitted to
brasileiro, o
neoadjuvant
estudo
treatment, the
Venus,
Brazilian
e o
study,
estudo
the
Nautilus,
Venus study, and
um
the
estudo
Nautilus
sul-coreano.
study,
Ou seja, no
a study
futuro
from South
próximo, a
Korea.
gente vai
So
ter
in the future, in
resultados
the near
de
future,
outros
we will
critérios um pouco mais amplos
need
do que o SOUND
other
apresentou,
criteria,
para
broader
que a gente possa,
criteria
talvez,
than what has been presented
omitir
so far, so that
o
we can
linfonodo
omit
sentinela nessas situações
the
de axila
sentinel lymph node in
ultrassonograficamente e
these
clinicamente
situations
negativas,
of
né?
clinically
Então, tem que fazer
negative axillas.
uma menção que nós vamos
So
ter
I need to say that we will
aqui no
have
Brasil um dado daqui a
here
alguns
in
anos
Brazil, we
desse
have
estudo que
data
está em
in a few
andamento,
years
que
from
está
this
sendo
study
recrutado
that
em
is
16
ongoing
centros
right
em
now.
todos o Brasil, então
That
nós
is happening
teremos
in
um
16
dado
centers
se é
throughout
possível
Brazil.
omitir
So we will have data
esse tipo
whether
de
or not it is
abordagem
possible
até
to
na
omit this
população
kind of approach,
brasileira, que
even
talvez
in
seja um pouco
the
diferente das
Brazilian
outras
population that
instituições
may be different
mundiais
from
aí.
other institutions, world
Enfim,
institutions.
podemos então fazer um downstage
So
da
we can do a
cirurgia axilar quando a
downstaging
gente tem um
of
ultrassom
the
negativo.
axillary surgery
Entretanto,
when we
quando o
have
ultrassom é
negative
positivo,
ultrasound, and
isso muda
especially
um
with a
pouco,
positive
né?
ultrasound, this
Porque
changes
a partir do
somewhat
momento que você tem uma
because
axila positiva,
when you have a
existe uma
positive
tendência
axilla,
hoje de a
there
gente
is a
oferecer a essas
tendency today
pacientes o
to
tratamento
offer these
neoadjuvante.
patients a
Mas
neoadjuvant treatment.
esse
However,
oferecimento do tratamento
this
neoadjuvante ele vai
offering
ser
neoadjuvant treatment
diferenciado, talvez,
will
nos
be
diferentes
differentiated,
subtipos
maybe
moleculares,
in
porque
different
a gente
molecular
sabe que
subtypes, because we know
a
that
taxa de resposta axilar ela
the
varia
rate of
a
axillary
depender do
response
subtipo molecular.
varies
Essa meta-análise de
depending
quase
on the
60 mil
molecular subtype.
pacientes
This
em
meta-analysis
33
with
estudos
almost
mostra
60,000
claramente que os
patients
tumores
from
mais
33 studies
responsivos
shows
são os
clearly that
HER2, os
the
triplo
most responsive
negativos, e
tumors
menos
are
os
HER2,
tumores
triple
luminares.
negative, and
E
least
isso
the
faz com que a
luminal
gente
tumors. And
pense
this
melhor
makes
em
us
cada
think
subtipo qual
better
seria a melhor
about each
abordagem.
subtype, what would be the best
E
approach.
sabemos também que a
And we
resposta
also
patológica
know
na
that
axila
the
ela é maior
pathological
que a
response in the
resposta
axilla
patológica na mama.
is higher than
Esse
the
estudo do
pathology
Memorial,
response in the breast. So this study
capitaneado
from
pela doutora Anitta
Memorial,
Mantani,
chaired by
mostra
Dr.
muito
Mantani,
claramente que as
shows
respostas,
clearly that the
no geral, ela é
responses
maior na axila
in
do que na
general,
mama,
they
e
are
em
higher
todos os
in the axilla
subtipos,
than in the
ela
breast. In
é
all
maior
subtypes
do que na
considered,
mama.
it
Ou
is
seja, a
higher
axila
than that in the breast.
responde
So the
muito mais ao
axilla
tratamento
responds
neoadjuvante. A
much
gente pode
better
utilizar
to
essa
neoadjuvant
estratégia
treatment. And
se o
we may
ultrassom
use this
detectar e a
strategy
punção mostrar que
if
aquela axila
ultrasound detects
ela é
and punction shows
positiva.
that axilla is truly
E como a
positive.
gente vai fazer isso?
And how do we go
Pensando
about
primeiro
doing
nos tumores
this?
triplo
Well,
negativos.
first thinking
Nos
about
dias
the triple
atuais,
negative
existe uma
tumors,
tendência
today
da gente iniciar o
there's a
tratamento para tumor
trend of
triplo
starting
negativo menor que
treatment
1
of
centímetro
triple negative
com
treatment
cirurgia. Isso
lower
talvez
than 1
seja
centimeter with surgery. And this
alguma dúvida,
may
mas no geral é isso, né?
there's some questions
Mas,
about this, but
se
this
fizermos o
happens in general.
ultrassom e
But if we did
analisarmos
the
um linfonodo
ultrasound
suspeito e
and
biópsia
we have a
positiva,
suspected lymph
isso
node
acaba
with positive
mudando e essa
biopsy,
paciente acaba
this
sendo
changes and this patient
selecionada
ends up being
normalmente para a
selected,
realização de quimioterapia.
usually selected
Então,
for
aqui é um ponto
chemotherapy.
importante do papel do
So that's an
ultrassonografia.
important point
E naquelas que
concerning
têm
the
tumores
role
maiores que 1
of
centímetro,
the
que
ultrasound in
frequentemente
patients
a
with
gente
tumor
já
larger than 1
indica
centimeter that
neoadjuvância,
frequently we
qual seria o
indicate
papel do ultrassom em
neoadjuvance. What
detectar uma
would be the
doença
role of the
naquela
ultrasound in
axila que
detecting
clinicamente é
disease in
negativa?
that axilla
O
that
papel
is
seria na
clinically negative?
mudança da
Well, the
neoadjuvância.
role would
Por
be in the
quê?
very
O
change
estudo
of
KNOTE
neoadjuvance
522
because the keynote study
mostrou que nas
522 showed
pacientes
that in
que têm
patients
tumores
that
T1,
have
T2,
T1,
com
T2
linfonodo positivo, elas
with positive
foram um
lymph
dos
nodes,
critérios de inclusão nesse
that
trabalho,
was one of the
que
inclusion
incluiu o
criteria in this
pembrolizumab
paper
na
that
neoadjuvância,
included
e aí a imunoterapia demonstrou maiores taxas de
pembrolizumab in
PCR e
neoadjuvance,
também desfechos
and
sobre vida livre de
immunotherapy
doença. Ou
showed higher
seja,
rates of
é
PCR
possível
and the
você
outcome
utilizar a
free from disease. So it is
ultrassonografia,
possible to use
fazer uma intervenção nessa
ultrasound
axila e
to
mudar
have
a
an
conduta
intervention in
dessa
that axilla
paciente,
and change the
agregando,
treatment for this patient,
escalonando o tratamento
adding
com
or
imunoterapia no triplo negativo.
de-escalating
No
treatment
HER2,
with
o
triple
cenário é
negative
muito
triple
parecido,
negative
porque os tumores
monitoring. In
iniciais, nos dias
HER2,
atuais, a
it
gente tem
is
uma tendência em
similar. Initial
iniciar o
tumors today,
tratamento
we
com
have this
cirurgia,
trend of starting treatment with
pensando que
surgery,
na adjuvância,
thinking that in
é possível a gente
adjuvance,
descalonar
it is possible to
quimioterapia, tirando um
de-escalate
antraciclo baseado
chemotherapy,
nos dados do
removing
APT trial, que mostraram dados muito
based
consistentes
on
de
the data of the
uma
APT trial
sobrevida
showing
muito boa
data
depois
very
de 10
consistent
anos.
data, very good survival in 10
Entretanto, um
years.
dos critérios para o APT
However,
trial é
one
ser
of the
axila
criteria
negativa.
for the APT trial
Se
is to have a
porventura o
negative
ultrassom
axilla.
detecta aquela
If by
axila
chance the ultrasound detects
positiva,
that
a
axilla is
conduta acaba
positive,
sendo
then
mudada,
the
você
treatment changes
acaba
and
oferecendo o
you
tratamento
end up
neoadjuvante
offering
e
a
aí
neoadjuvant
escalonando o
treatment
tratamento.
and
No
scaling
caso,
up the
com
treatment.
duplo bloqueio com trastuzumab e pertuzumab,
In the case
baseado
of
no
double block
Gelspir
with
para enfermidade
trastuzumab and
infantil,
pertuzumab
ou
and
nas situações,
anthracyclines.
por exemplo, no SUS,
In
que
these
não
situations
está contemplado na
in which
neoadjuvância ao pertuzumab, quem
in which
sabe
there's no
incluir a
adjuvance to
antraciclina, que não seria incluída
pertuzumab,
na adjuvância,
maybe
se a gente
adding
usar o esquema
anthracyclines that would
do
not
APT
have been
trial.
included in the adjuvance
E hoje
if
em
we
dia, por
use
exemplo, aqui na
this
Unicamp, a gente faz essa
scheme.
estratégia na
Today at
neoadjuvância e
Unicamp, we
inclui a
use this
antraciclina
strategy.
também, por não ter a
In
possibilidade do
neoadjuvance
pertuzumab.
treatment, we include
O
anthracycline because
cenário
we don't
mais
have
incômodo e
pertuzumab.
mais
The most
complicado é no tumor luminal. Por quê?
complicated
A gente
settings
tem
is in the
algumas
luminal tumor
possibilidades de
because we have
ultrassonografia da
some
axila. A primeira é,
possibilities
né,
of
quando o ultrassom é
ultrasound in
negativo,
the axilla.
e
First,
aí,
when
como eu
we
já
have a
disse para você, a gente
negative
pode omitir o
ultrasound,
linfonodo
and as I
sentinela.
said, we may
Uma outra
omit
mais
the
fácil de você determinar qual
sentinel
seria a
lymph node.
conduta é quando
Another
ele é
one,
suspeito com
easier
uma
to
alta
establish the
carga
approach, is when it
tumoral.
is
E
suspected with
aí,
a high tumor
geralmente a
load.
gente indica
And then
neoadjuvância. A questão
we
é aquela
indicate
situação em que
neoadjuvant
tem
treatment. The
uma baixa
issue is
carga
that this,
tumoral, você faz
when
um
you have
passo.
low
Se ele for
tumor
negativo,
load,
talvez eu possa
and if it's
oferecer
negative, I
uma
may
omissão do linfonodo sentinela, mas se
omit the sentinel lymph node, but
se
when
essa axila é positiva com uma baixa
this
carga tumoral,
axilla
existe uma
is
dúvida. Vou para
positive with low
neoadjuvância ou faço
tumor
cirurgia?
load,
O que a
either
gente tem de
neoadjuvance or
pró
surgery,
para
what we
fazer a
have
cirurgia
pro
e qual cirurgia é o
for
quê?
surgery and
Existe
what
a possibilidade
surgery
de eu
is.
pensar em fazer uma
There's a
biópsia do
possibility of
linfonodo
thinking about
sentinela,
doing a sentinel node
mas
biopsy,
e enquadrar essa
but
paciente na possibilidade
and then have this
de
patient fit the
incluir num dos
possibility
critérios do Z11.
of including it in
Isso
the
não tem nenhuma
Z11
evidência
criteria.
científica,
There's no
e diminui o
scientific
risco de
evidence
uma
here,
linfadenectomia
and it
axilar,
reduces the risk
né?
of axillary
Isso fez com que alguns trabalhos
lymph node
mostrassem que a
removal.
ultrassonografia
This
nesse
made some
cenário com
studies show
axila
that
clinicamente
ultrasound
negativa
with a
pudesse
clinically negative
aumentar a
axilla
taxa de
may
cirurgia
increase
na
the
axila, e
rate
alguns
of axilla
autores até
surgery.
recomendavam
And
não
some
realizar o
authors
ultrassom
would
no
even
C
recommend
contexto.
not
Com o
doing
estudo salvo,
ultrasound
isso veio
under this
cá
situation.
por
The
terra,
sound trial
porque hoje
brought this
precisamos do
down
ultrassom para falar que
because
essa axila
today
é
we
negativa
need
para a gente ter a
ultrasound to say
possibilidade
whether
de
or not
omitir
this
o
axilla
linfonodo
is negative
sentinela,
so that we
né?
can
Então, qual
omit
seria a
the
melhor
sentinel
conduta
lymph node. Now,
nesse
what would be the
sentido,
best
pensando em
approach
operar
in this
primariamente? A gente
sense?
entender que o
Well, we
ultrassom
have to
ele
understand that
pode prever
ultrasound
aquela quantidade de carga
may help
axilar,
predict the
ou seja, ter
axillary
uma
tumor
quantidade
load.
pequena de
In other words, having a small tumor load in the axilla. And this meta-analysis shows that this is possible when you compare with the multiple suspicious lymph nodes. You have a specificity and a very good sensitivity and specificity to establish the axillary load. And this changes a little when you have a cutoff of 2 compared to a lymph node, but maybe here it is possible to think about this possibility, but this is very much out of the protocol. There's no scientific evidence here, and they do not do primary surgery thinking about sentinel node. I indicate this patient to neoadjuvant treatment. I refer them to neoadjuvant treatment because I can de-escalate the surgery.
Mas também tem alguns contras essa
also, there are some factors against this approach. One of them is the risk of overtreatment. We're treating women that could fit the settings of postmenopausal with low axillary load and with the risk lower than 25, in which we know there's no benefit of doing chemotherapy or indicate neoadjuvant treatment to something that in the adjuvant treatment I would not indicate. But I'm also in such a setting, I'm afraid that the woman with this condition of neoadjuvant treatment, the luminal tumor tends to have a worse response than the other subtypes, and by sometimes after surgery, doing a sentinel node biopsy and remaining with a positive axilla, we might have to do axillary dissection, and this may change in a few years with the presentation of the results from the Alliance study 11202, in which they randomized patients in this setting post-neoadjuvants to do complete surgery in the axilla, dissection or treatment in the axilla with radiotherapy. If the study shows that radiotherapy is not inferior than surgery, this may help us establish that these patients may be included in neoadjuvants, and if there's no response, I can do only radiotherapy afterwards. So finally, to conclude, what is the role of the axilla or the axillary ultrasound in the intervention? To de-escalate or escalate? Well, it is both. It will de-escalate if it is negative or suspicious with biopsy or negative function within the sound trial criteria, in which we can omit the sentinel node, and in a few years, some studies will add results to the study. One of them is the Brazilian study, the venous, or escalated. If the lymph node is positive, thinking about the intervention, selecting patients for neoadjuvant treatment, for example, triple negative lower than T1, HER2 lower than 2 centimeters, and those luminal with high load of axillary disease, or changing neoadjuvant treatment, including immune therapy in the triple negative. And it is not very clear considering the best approach for luminal tumors with low load of axillary disease. Today, I have a tendency here to favor neoadjuvants, knowing about the pros and against factors that we discussed before. Thank you very much for your attention, and enjoy the rest of the meeting.
Thank the organizers very much of this exciting Breastmit 2023 for inviting me to talk about a hot topic in breast cancer surgery, whether we are comfortable in omitting axillary staging for T1N0 breast cancer, and to give you some insights from the SOUND trial that has recently been published. So as you all know, breast cancer surgery has been de-escalated during the past decades from very radical surgery to the breast and the lymph nodes to much less surgeries, breast-conserving therapy, less extensive surgery to the axilla, and at the same time with much better survival rates. Regarding the de-escalation of axillary surgery, about 50 years ago in the 60s and 70s, radical removal of all reachable lymph nodes was performed, including thoracotomies for internal nodes, but it has been shown in randomized trials that these procedures did not have the effect of better outcome. More than 30 years before, we performed radical axial lymph node dissections of level 1, 2, and 3 as a staging procedure, but also as a therapeutic procedure. And about 20 years ago, the sentinel lymph node biopsy was introduced as a staging procedure for clinically node-negative patients to determine the axillary nodal staging to tailor adjuvant treatment decisions. And from 2010 on, we learned from the Z11 trial that in patients with low tumor burden in the sentinel lymph node, no axillary section was necessary. Way back in 2005, the Early Breast Cancer Collaborative Trialists Group could show that full axillary lymph node dissection was of no benefit with regard to overall survival if it was performed within a multimodal concept, including radiotherapy, for any reason, for breast-conserving therapy or the thoracic wall. And in 2016, Armando Giuliano presented these data from the Z11 trial, showing that patients with 1 to 2 involved sentinel lymph node benefits did not derive any benefit from axial lymph node dissection. So these are the standards of today. These are German guidelines showing that axial lymph node dissection is not recommended there's no benefit for survival. It should not be performed for axillary staging, and there is a questionable benefit even for local regional control. However, we know that the lymph node status is still an important prognostic factor to tailor adjuvant treatment decisions, and the prognosis depends on the number of involved lymph nodes. Therefore, sentinel lymph node biopsy today is a standard of care for all invasive breast cancers, at least in Germany, and you see that in patients with clinically and sonographically negative axilla, it is recommended with a double plus, means there's a very high recommendation grade, and it is performed in practically all patients. However, the therapeutic implications of the lymph node status is declining. With regard to surgery, and as we said, axial lymph node dissection is no longer performed in patients with low nodal burden. The implications are reduced for adjuvant systemic treatment because in luminal A tumor, we perform endocrine treatment irrespective of nodal status. In luminal B tumors, we have grading Ki67 gene expression profile to define on adjuvant chemotherapy. HER2-positive patients undergo chemotherapy plus antibodies, irrespective of nodal status, and triple-negative patients with triple-negative disease will undergo chemotherapy anyway, mostly in the neoadjuvant setting with checkpoint inhibitors, and there's a minor impact on radiotherapy. And therefore, back in 2019, the ASCO already recommended that for patients elder or equal to 70 years with clinically node-negative T1 and 0 early-stage invasive breast cancer and hormone receptor positive and HER2-negative disease, sentinel lymph node biopsy was not required. However, it was stated that this was an informal consensus and evidence quality was insufficient. In the same time, there were 2 randomized trials running, the SOUND trial from Italy and the INSEMA trial from Germany. The SOUND trial included 1,560 patients with tumors up to 2 centimeters, any age, and patients had to be candidates for breast-conserving therapy. The INSEMA trial included 5,940 patients and included T1 and T2 tumors and had 2 randomization phases. The first one between sentinel lymph node biopsy and no surgery, and a second randomization for patients who had underwent sentinel lymph node biopsy and then were randomized to full axillary section or no further surgery according to the Z11 concept. Interestingly, the life quality data from the INSEMA study were presented at the San Antonio meeting in 2021. And as expected, we could see for patients with sentinel node biopsy compared to full axillary section as were performed in the Rando 2 from INSEMA, there was a significant difference in arm mobility. But now look at patients who underwent sentinel lymph node biopsy and no further treatment, and there was also shown that there was difference in arm mobility. And interestingly, the difference between the extent of morbidity was very similar between axial resection and central lymph node biopsy as to central lymph node biopsy and no further surgery. So omission of central lymph node biopsy would certainly improve life quality. And this is the first trial that was published by my colleague and friend Oreste Gentilini from Milano and co-founder of UBreast, that randomized patients with tumors of less than 2 centimeters, any age, breast-conserving therapy, and a negative ultrasound of the axilla, or a negative fine needle aspiration in a single doubtful node to undergo central lymph node biopsy or no axillary surgery, and about 800 patients were randomized per arm. And I'm very happy to announce that the paper was published very recently in JAMA Oncology on September the 21st, 2023. Now, these are the results of this trial. The mean age of the patients was around 60 years. The menopausal status was peri or postmenopausal in almost 80%, and the mean tumor size was 1.2 centimeters in both groups. Now, the involvement of axillary lymph nodes was 84% of the patients in the central lymph node arm had negative lymph nodes, and 13% had 1 to 3 positive lymph nodes. And among these, only 11% had 1 involved lymph node. So in this cohort of patients, 96% of the patients had no or maximum 1 involved lymph node. So looking at the results of the trial, the 5-year distance disease-free survival, and it was a non-inferiority trial with the aim to show non-inferiority of omission of axillary dissection compared to central lymph node biopsy. So the 5-year distance disease-free survival was 97.7% in the central lymph node biopsy arm and 98% in patients who had no axillary surgery. Very similar for disease-free survival. The curves were almost overlapping and no difference was found between the central lymph node biopsy group and the no surgery group. Very similar as well, the cumulative incidence of metastasis, also overlapping curves and no difference. And as expected, the incidence of axillary recurrences was very low. Among 780 patients who underwent central lymph node biopsy, only 3 events were registered, 0.4%, and for patients who were in the observation arm, 5 events corresponding to 0.7% were observed. So in conclusion of the SOUND trial, we can say that omission of axillary surgery was non-inferior to central lymph node biopsy in patients with small breast cancer and a negative ultrasound of the axilla. The outcome is excellent in this group of patients, and it has also been shown that ultrasound is a valuable tool to select patients. Now, we should discuss the trial, and what we can say is that we can, or the question is, can we spare all patients who fulfill the SOUND criteria from surgery axillary staging? It should be noted, however, that, and this is a small limitation of the trial, that the radiation volumes were not defined in the SOUND trial. So the question is open: how should target volumes of breast irradiation be defined? There's certainly, and this we can conclude this, there's certainly no therapeutic benefit of central lymph node biopsy itself, but the question remains which patient benefits from the information on the PN status as a prognostic factor, and central lymph node biopsy is a diagnostic procedure and requires that we perform in order to tailor further adjuvant treatment decision. So what is the impact on further surgery, on adjuvant radiotherapy decisions, and adjuvant systemic therapy? Now, it has been shown in the SOUND trial that only 0.2% of the patients had more than 3 positive central lymph nodes and might therefore benefit from further axillary surgery. Patients up to 2 lymph nodes, in these patients we can omit axillary section, and for patients up to 3 lymph nodes, we can do irradiation according to the Amoros trial. So a very, very, very small cohort would derive any consequence for surgery. What about the impact of nodal status on the effect of regional radiotherapy? Again, only 0.2% had more than 3 lymph nodes, and it has been shown in these meta-analysis of the EBC-CTG meta-analysis that was presented at San Antonio 2018, that only patients with a high nodal burden of 4 or more lymph nodes in the axilla had benefit with regard to survival from regional irradiation. So again, very small benefit from the information for tailoring adjuvant radiotherapy to the regional lymph nodes. So what about the impact of nodal state on systemic treatment decision? And there we have some potential impact. So no positive premenopausal women with luminal B tumors, they might benefit from chemotherapy. Patients with HER2-positive disease and a positive lymph node status might derive benefit from additional pertuzumab, which is about 2%. Patients with with ER-positive, HER2-negative disease might derive benefit from CDK4/6 inhibitors, as has been shown in the NATALEE study. But again, the benefit is small, and patients with node-positive disease might benefit from bisphosphonates. So in conclusion, we can say that central lymph node biopsy can safely be omitted in most postmenopausal T1N0 patients with early breast cancer, and ultrasound is recommended in preoperative diagnostics. The rate of PN plus was only 13% in the SOUND trial. And among these, some, mainly premenopausal, patients might benefit from improved systemic treatment. So the decision to omit axial lymph node dissection should therefore be discussed preoperative within an interdisciplinary team, including medical oncologists and radiation oncologists. Further insight will certainly be provided by the INSEMA study that will be presented in the very near future. In this trial, T1 and T2 tumors were included, and the target volume for the radiotherapy was standardized. So in conclusion, I think the door is open now to leave central lymph node biopsy as a standard for all patients with invasive breast cancer. And we have certainly defined exactly the subgroup where we can safely reduce the extent of axillary surgery. Thank you very much.
Thank you so much for the opportunity to share some thoughts with you on repeating breast conservation surgery and breast conservation generally after recurrence of breast cancer in the same breast. I don't have any conflicts of interest, but what I'm going to try and do is draw on some European practice that I had, and also now working in Houston, Texas, I of course bring you greetings from Houston. What I'd like to do over the next few minutes is just briefly touch on a background, then focus a little bit on trying to work out what are these second cancers in the same breast, make some passing notes on some recent clinical trials, and also some of the current trials and proposed trials in this arena, and finish up by thinking, what would I be doing? What might you want to consider doing on Monday morning when you're faced with a patient who has a second cancer in the same conserved breast? So, in summary, 3 to 10% of women have a second cancer in the same breast after breast conservation surgery. And I think that number is widely accepted, so I won't delve any deeper into that. What is perhaps a little more interesting is to think about what are these second cancers? And I'm going to split this into DCIS and invasive cancers as 2 different considerations, as you'll see, for good reasons. So if the original cancer was DCIS, primary DCIS, shown on the left-hand side of the screen, we did a very large study in the Netherlands, the UK, and the United States to try and work out the nature of the recurrent or the subsequent invasive ipsilateral cancer in that breast. We also looked at the same-sided DCIS that recurred in that breast. And you can see in the bottom part of this slide that the average time for a new invasive recurrence to occur in that breast, in the breast that had had primary DCIS, was about 5 years, but ranged considerably between 1 year and 17 years. And so considering that matched primary DCIS with the matched ipsilateral invasive recurrence, we were able to demonstrate in this paper published recently in Nature Genetics that 4 times out of 5, the original in situ DCIS was actually the source of the new invasive cancer. We were able to show shared clonal lineages from a single common ancestor. However, in 1 in 5 of the cancers, the invasive cancers that arose from the DCIS, the new cancer was clonally unrelated, and so clearly the invasive cancer had come from a different clone to the in situ. So 1 in 5 invasive cancers after DCIS are not from the original. 4 out of 5 are from the original DCIS in terms of clonality. Let's think now about invasive cancer. And here I'm going to restrict ourselves to hormone receptor positive invasive cancer. On the left hand of the screen, you can see that the invasive cancer has recurred as a new invasive cancer on the right-hand side of the screen. And the question is this truly a recurrence or is it a new primary? And in this recently published work from the French group, you'll see that in 18% or 1 in 5 of the new primaries, in fact, it was simply a recurrence of the prior primary because genes like Iridia, NSD2, SET-T2, and others were actually present in the original cancer and were now present in the second recurrent cancer. But in contrast to DCIS, 80% of the new primaries were actually truly new primaries and did not appear to have an origin in the original invasive breast cancer. Now, whether this changes with more subtle single-cell analyses in the future remains to be seen. But to summarize what I've just been saying, it looks out as though 4 out of 5 DCISs recur as invasive clonal invasive cancers, but only 1 out of 5 invasive cancers are clonal with a subsequent invasive disease. So enough science. Let's turn to some recent clinical studies. And you can see here that what we're going to do is, first of all, again, look at DCIS. And in this recently published work, you can tell that the Van Nuys prognostic index and Memorial Sloan Kettering nomogram were really not terribly good at distinguishing those patients who would recur versus those who would not recur. And the probability value, the significance was not significant. So certainly for DCIS, we can't tell from any of the usual prognostic models who's going to recur. Turning to invasive cancer, of course, things are a little bit more complicated because we traditionally break down invasive breast cancer nowadays into hormone receptor positive, HER2 negatives, hormone receptor negative, but HER2 positive, and triple negative breast cancers, the 3 bullet points on the left there. And you can see in this figure drawn from a recent publication in JAMA Surgery that for the hormone receptor positive cancers, the ones at the bottom of this graph, there really is a very smooth, no peak, but a sort of 1% per annum recurrence in the breast. Whereas for HER2 negative and B2 positive, the blue dotted line, or for the triple negatives, which is the very difficult to see yellowish gray dotted line, you can see that there are 2 peaks. In the first 3 years, the HER2 positive cancers or the triple negative cancers can occur, but then there's a much later peak at about the 8-year mark. So this raises the question of whether we should actually be looking for new ipsilateral cancer in a different way. In the estrogen receptor, hormone receptor positive cancers, it's a consistent 1% per year or thereabouts, almost for 10, 15 years. Whereas in the triple negatives and the HER2 positive breast cancers, it may be that we should be looking for a peak in the first 3 or 4 years. So others have looked at this, and we're beginning to recognize that early relapse within 24 months, these may be more aggressive cancers generally, but trying to work out from your original primary cancer what's going to happen remains very difficult. So what about some of the evidence from largely retrospective studies? Well, the first question I wanted to think about was, if you have breast conservation and then you repeat your breast conservation, do you need to repeat the irradiation? And clearly from this large systematic review, relatively recently published, at 5 years, if you have repeated breast conservation, then you've got a 77% survival, 76% local control. If you've had repeat breast conservation and repeat irradiation, then you've got a much better control, 87% survival, 89% local control. So if you're going to repeat breast conservation, you do need to repeat the radiation too. And that raises the issue of, well, wouldn't you be better just doing a mastectomy? Well, here are 2 bits of evidence which suggest, the top there, with 6 years of follow-up from one of the European groups, that mastectomy compared with lumpectomy with radiation therapy, there were really no differences in either overall survival or in a third event. By that I'm meaning a third cancer in the same breast. And then if you look at the lower part of this slide, the long-term survival outcomes after repeat lumpectomy compared to mastectomy, in a largish retrospective study at about the 10-year mark, there was really no difference in overall survival or breast cancer specific survival. So mastectomy compared to breast conservation, with the caveat that you really do need that radiation treatment a second time, do look as though they're equivalent. Okay, so what about some of the current and proposed studies that are ongoing? Well, here I think we have to turn to the NRG US study, the 1014 trial, which had ultimately some 50 patients in it. And they used 30 fractions given over 15 days. In other words, each day the patient had 2 fractions of radiation, 1.5 grays twice a day. And although they had some significant adverse events, you can see that there was a low in-breast recurrence, IBR, rate. And although giving radiation twice a day may not be really logistically terribly easy and can be quite costly from an institutional and a patient perspective, and one has to wonder about the toxicity, this has become the standard of care in the United States, where after repeat lumpectomy, the repeat radiotherapy is given twice a day over 15 days. And that's considered to be our safe standard of care in the United States. However, others have been very thoughtful, and some colleagues in the Northeast, including at Memorial Sloan Kettering, have done a recent 2-center study, retrospective, yes, but you can tell that most of the patients who had invasive disease have had further recurrences. They're all node negative, and those patients have had a partial breast irradiation regime. Choice between 3 different regimes, most of them getting the NRG 1014 1.5 grays twice a day, some getting the 1.8 grays daily. But whichever regime they've had, partial breast irradiation, the 2-year overall survival and local recurrence and recurrence-free survival has really been excellent. And this suggests that there may be a different set of regimes that could be applied to such patients without disadvantaging patients. There's also a Canadian trial, the PRESERVE trial, which is just underway, and that pilot study of 15 patients is comparing what we'd conventionally think of as a more standard whole breast radiation theme or versus a hypofractionation regime of 26 grays and 5 fractions, which has become a very attractive standard of care in the first breast conservation setting. And really this very thoughtful Canadian group led by Eileen Rakovich have been trying to work out whether the issue is it the primary breast, the primary cancer that's been radiation resistant, or is it a new primary that they're able to treat just as readily. Toxicity and the feasibility of doing this are two of their key endpoints, but they're really looking to see, is this short 5-fraction regime, which works so well first time round for primary breast cancer, is this just as good in the second breast conservation surgery setting? Now, there are some other things which we do need to consider. What should we think about the axilla? Now, most of us, I think, would say, let's exclude those patients who are node positive in the axilla and think of them as a different group. Should we be treating the recurrence, the second cancer in the same quadrant differently to a second cancer in a different part of the breast? Perhaps we should. Should all subtypes, DCIS, invasive cancer, lobular invasive breast cancer, be treated the same or differently? We probably need to think about them slightly differently, but as you've already seen, although the biology may be different, you may be able to apply second breast conservation just as readily. And that may pertain even if the patient has originally had some sort of oncoplastic rearrangement of the breast as her original breast conservation surgery. And then there's the issue of whether originally the patient had whole breast radiation therapy or originally had partial breast irradiation or intraoperative radiotherapy. All these nuances of radiation and how it's been delivered may impact what we do the second time around. Now, overall, I guess this is the background, and I've been thinking about this a little bit and thinking, what am I going to do next week when I'm faced with a patient who's had previous breast conservation and is now coming back with a second cancer in that breast? What do I do on Monday morning? Well, as ever, I'll be scratching my head a little bit and thinking, what do others feel? Well, we know the St. Gallen conference, the 17th consensus conference in 2021, was pretty much in favor of still doing a mastectomy for those who have early recurrence. Maybe was backing off a little bit for those usually hormone receptor positive patients whose recurrence is sometime later, maybe a decade later, where more of the expert consensus conference would consider breast conservation a second time with a radiation. And of course, what I would like to suggest is that we should be getting a sentinel lymph node biopsy for the axilla in this setting of a second breast conservation, if we can suggest preoperatively that the axilla is negative. So what would I do on a Monday morning? Well, I would tend to use repeat breast conservation approaches on the patients if they are willing and if they're keen to keep their breasts. With that, obrigado. Very happy to have had time to speak with you. Exciting conference. And I wish I was with you in person, but this virtual reality conference is a great way to go. Thank you so much.
Olá a todos, é uma honra para mim estar aqui conversando pouco de
It's an
tema
honor for me to be
difícil,
here with you to talk about a
controverso,
difficult topic, somewhat
que seria a
controversial,
reirradiação
and
segundo
that would
tratamento
be
cirúrgico
re-irradiation, a
conservadora
second
numa
conservative
recidiva local.
surgical therapy
Então,
in
esses
local
são meus
recurrence.
conflitos de
So these are
interesse.
my
Eu
disclaimers.
acho que a gente sempre que
I
pensa
think
numa
that
reirradiação de
whenever
mama,
we think
eu
of re-irradiating the breast,
nesses
we
três
think of
cenários, na
these
verdade. Uma
three
paciente que
scenarios,
fez
in fact, the
irradiação de mama
patient that
total, tem uma
was irradiated
recidiva.
in the total breast
Uma
without
paciente que fez uma
recurrence, a
radioterapia
patient
parcial
that
e tem
did
uma
partial
recidiva, ou uma
radiotherapy and
paciente que
recurrence,
fez uma
or a
mastectomia e
patient that
irradiou o
did a
plastrão e tem uma
mastectomy,
recidiva no
did
plastrão.
do
Nesse
radiotherapy
cenário
and
1,
has
será
the
que
recurrence
sempre
there.
a
In
gente
scenario
precisa
1,
fazer
should we
mastectomia,
always have to
né?
do a
E nesse
mastectomy?
cenário 2,
And in
eu não vou me
scenario 2,
atentar muito
I won't go
porque
into this very
muitas
much
vezes é bem difícil uma
because
nova
often it's very
ressecção
difficult
depois de uma recidiva em plastrão
to
e a
resect again
radioterapia
after one
que
of
entra
those
na grande
big
maioria das
resections.
vezes como
And in
tratamento
most
exclusivo ou
cases,
paliativo. Então,
this
acho
is
que
more
esse
of a
primeiro
palliative nature.
cenário
So
que é o que a
in this
gente vai
first
falar.
scenario, the
Então,
first part, the
se
top part
você
of the
for
slide is what
no
we're going to talk about.
NCCN ou
If you
qualquer
look at the
outro
NCCN
guideline,
or any
recidiva
other
local
guideline,
que
local recurrence
inicialmente fez cirurgia conservadora com
that
radioterapia
originally
é
had
igual
conservative
a
surgery and
mastectomia,
radiotherapy
tá?
would be equal to
Então,
mastectomy
qualquer
with the recurrence. So any guideline, you will find this. You will find that mastectomy is mandatory in these patients. However, when we look at why this is so, why do they reach this conclusion? We look at the meta-analysis that was published in 2021, which is the largest of them. We see that, in fact, the meta-analysis has a trend that favors mastectomy rather than local resection. But when we look into more detail into these cases, into these papers, we find that only 24% of these studies included conservative surgery. So it wasn't paired, and many papers, all the papers with radiotherapy of the 70s and the 80s were included. And the question is mastectomy in fact enough? Is mastectomy sufficient? In this systematic review published in 2017 by the MD Anderson group, we find that after a mastectomy with recurrence, the recurrence when not radiated is about 20%, with an overall survival of 68%. So very probably we think of only doing mastectomy later, this will generate frustration and maybe it will not solve the problem.
I present this case here, 58 years of age, 2010, had a right breast in situ carcinoma. At that time, they did 60 gray with boost plus tamoxifen. She took tamoxifen for 6 years. And now in 2022, a new nodule in the right breast, biopsy, IDC, grade 2, patient does not want a mastectomy. What to do? Well, to answer this, we will go to the literature to see whether or not there is some paper that assessed a conservative treatment, conservative surgery, and radiotherapy in this patient. So there is this review published in 2022, and these are the main studies that discussed this issue. So we see that almost all of them have a small number of patients, except for this paper from Handu, which is a French paper that they did brachytherapy, but we see there that most of these studies used brachytherapy as a standard treatment. Most of them are older studies. The minimum interval of 70 months between the two radiotherapy pulses, but reaching 216 months in this Chinese study. And we see here local control, overall survival. That is very interesting. Local control here vary between 89 and 100% with a global overall survival. That is very interesting. The worst survival is this one here, the largest study, which was with a brachytherapy only. But you see here that this survival here is an analysis in 10 years, so it is not that bad, and with a very acceptable toxicity, a bit worse for those patients that undergo brachytherapy. And I'd like to stress here R2G 1014, which is the most recent study with a radiotherapy, modern radiotherapy, that utilized partial irradiation. Now I'd like to show you local relapse in 3 years of 3.4%, 5 years 5% only, and with 95% of overall survival in 5 years, which is excellent. And you see here the very low toxicity, no grade 4 or 5 toxicity. And this very interesting paper published by the European group, Jack Astro. So what they said, well, since there's no data, there are not too many patients. Most of the studies have a very small number of patients. Let's try to do a large European study. And of course, a retrospective study, but a study that managed to include 1,300 patients, 945 with a salvage mastectomy, and 382 with a new conservative treatment with radiotherapy. And these patients then, they were paired to know whether or not there would be a difference between doing mastectomy or doing the conservative surgery with a new radiotherapy and the relapse. And you see that when we look at the questions, we see that none of them showed a statistical difference right? So the incidence of ipsilateral tumor, the incidence of regional relapse, the incidence of distant metastasis, disease-free survival, specific survival for breast cancer, and overall survival, there was no difference. And here we see the charts. The incidence of relapse in the same breast was not significant. There was no difference in terms of regional relapse, no difference in specific survival for breast cancer, nor for overall survival. And then we think, great, excellent. But what do we do? How do we irradiate these women? Well, first we treat the entire breast, we treat partially. With what technique, with what dose? Well, the studies that assessed this, as I said, are all small studies, but look at how interesting this is. The studies that did partial radiotherapy, this in the relapse, okay? Remembering that we're talking, all these women are women of relapse. We see here that a low rate of local relapse, and we see an excellent result in cosmesis. But the women that underwent radiotherapy of the entire breast, we see here a worsening in the aesthetics. So the conclusion of all these studies was that when you re-irradiate the entire breast, the likelihood of having severe skin problems, permanent telangiectasis, likelihood of having a coastal arch fracture increases because the exposure area increases. So there are a number of things like the chance of edema increases. So it is very likely that as far as toxicity is concerned, it is much more toxic to re-irradiate the entire breast. So the suggestion from the entire literature is not re-irradiate the entire breast and preferring partial irradiation. So in this setting of partial irradiation, these are the ongoing studies with a focus on partial irradiation. We see papers with intraoperative studies, papers with SPID, protons. We have a number of studies ongoing here, and we are waiting for the results from these papers. But reminding the breast surgeons here that whenever we think about partial irradiation, we need to know where the bed is. So please, whenever, remember that we have to clip the disease bed here. Here I know where I need to treat. Although it is not clipped here, I know as well because there is an area of fibrosis that ended up happening here around the scar tissue. But this here I have no idea where I need to irradiate. You see that here, I only know that it is the right breast because there is a mark here, an external marking here from the scar. So it is very important to remember to clip the bed if we think about partial radiotherapy, being as a main primary treatment or in a relapse treatment. Now, going back to the previous case, the patient was submitted to a segmentation of the sentinel node, CDI grade 3, 1.5 centimeter, negative margin, 3 free lymph nodes, oncotype 9, risk 9, mysteriously, hormonal receptor 100%, KI 7, 40%. So this is the picture of this patient and the pre-radiotherapy marking, and this is the picture of this patient now, 18 months after treatment. So you see that her aesthetics is excellent. The patient is very happy and is following with a hormonal block. And so I think that going back to that initial flow chart, I think that yes, in selected cases, we may consider a new radiotherapy, a new conservative treatment, and a partial radiotherapy. However, in women that cannot, for some reason, operate, we may think about some treatment for a tumor present. So with radiotherapy, some curiosities here. The main of them was the issue of the axilla. We know that it is safe not to do dissection. We have many older papers trying to do radiotherapy alone for ladies with some other risk factor that could not be operated. But the truth of the matter is that since 1903, the guy who invented the telephone, he also dedicated to radiotherapy, and he already puts the seed, the radiotherapy seed, inside tumors, and also breast tumors. And there's a radiosurgery study that shows that it is very old. We started with this idea doing radio surgery for brain tumors that could not be operated, this during the 70s. And we ended up taking 40 years to leave the brain, because the brain, if you consider on this box, we know that the brain is in the same position, but we can tie an entire person and the person continues to breathe and everything is moving and the breast moves as well. Today, we have beautiful machines that we can know exactly how the patient is breathing, how this tumor is moving. We can also choose the phase of the breathing, of the respiration we can treat. We can know, understand, and execute the treatment in a very efficient way. And with this, we can use very high doses in a few days anywhere in the body. This is well established. It was taking time for us to start doing this in the breast. And there is a paper, an ongoing prospective randomized paper for women with over 75 years that cannot or do not want surgery. And on the Astro, they presented a very interesting paper about what dose is enough to kill, sterilize a tumor. And they discovered that a single dose of 34 gray, you can sterilize in 93.3% of the cases. So this is very, very interesting. And the colleagues from cryoablation are more advanced than we are. They already presented this study here, the ICE-3, with almost 200 patients with 98% of satisfaction and 100% of local control, remembering that these women do not comply well to hormonal blocks. So oftentimes we think that these old ladies, well, this is a relapse, let's leave them, a hormonal block only, but this acceptance is not that good. And oftentimes you will see a lady, for example, a 91-year-old lady who has no condition to be operated, and this is the aesthetic result with excellent local control. And to end, I think whenever we think a new conservative surgery and a re-irradiation, some issues must be considered. What is the goal of the treatment? It is palliative, radical. Does it make sense to have a new conservative surgery depending on tumor size, on patient desire, the tumor breast ratio, how long ago this patient irradiated, less than 1 year? Maybe it is a radio-resistant tumor. What was the skin like after the first treatment, and whether or not this patient has other risk factors for toxicity, diabetes, obesity. In this case, we should prefer partial radiotherapy when we understand all these answers. And I think that we must always try to individualize it case by case and not treat all women as if it were just one more in the crowd. Thank you very much. Well, first of all, congratulations to everyone for your excellent presentations, for the very brief discussion, well discussed. And before we start, before inviting not only the speakers as well as the moderators to join our discussion, I would like to make it clear that I am very excited to see, as a surgeon and as a person who is also working with breast images, I'm very excited to see this change that we see in front of us. I believe it is a way, there's no turning back now, to be able to bring these patients a surgical treatment without inferiority compared to what we had been doing before, and with a better quality of life, which is the most important thing that they are enjoying with the treatment that evolved from adjuvancy, from radiotherapy and oncology. And we were still needing, from the most recent studies, the Z11, the 1071, the Amaras, we were a bit stuck there. And I believe this path makes me very excited to talk here about it. I will invite the speakers now and I'll call the moderators of our panel. Pedro Santos, oncology, clinical, member of the female tumors department of the Oncoclínicas Belo Horizonte, coordinator of the breast oncology team in Vila da Serra, member of SBOC ESCO. Also invite Dr. Barbara Passe, PhD in medicine by the University of São Paulo, chair of the Brazilian Society of Mastology, Minas Gerais chapter, and a breast imaging of sonar breast medicine. And also Gabriel Gil, master's and PhD by UNESP, radio oncologist at the Mater Dei Healthcare Hospital, MBA executive by Dom Cabral Foundation. And I will leave it open for you. Let's start maybe Dr. Passe. Dr. Passe, besides being an image expert, is also a surgeon. If you would like, Barbara, to start. Yes. I'll start. Good afternoon, everyone. First of all, I'd like to thank you for the invitation and especially congratulate Enrique Couto for the success of one more Breastmit. This meeting is really part of our calendar. It can join people from all over the world, which is great, and I hope we can keep this meeting happening every year. And also, I'd like to congratulate the speakers for the brilliant presentations. I liked it very much when Professor Giuliano started talking about ultrasound to de-escalate and also to escalate treatment. Because although I work with breast image, but I'm also a breast surgeon, every day I think more and more about the real need to biopsy sentinel node in all patients. I think that although a surgical morbidity may be very little, I don't see much benefit in terms of cure, prognosis. Therefore, as it was well presented by Professor Cohen, I'd like to know, after the data presented by Saldo, what is still missing to have in our daily routine the not doing the sentinel node. What do you think? When will this become a routine? As they did in the sound study. Please. Dr. Cole? Dr. Khan, if you didn't understand the question, I can repeat it to you.
Yeah. Can you hear me?
Yes.
Can you? Yeah. Okay. First of all, I have to apologize because I didn't get home in time. So I'm sitting in the fully packed train. So, and I tried to do my for the discussion. Yeah. So the question was, if I understand correctly, if we translate the results from the sound trial into clinical routine, is that correct?
Yes.
Yeah.
We need to use it.
So certainly in Germany until this year, 2023, the sentinel node procedure was a routine procedure in every patient with invasive breast cancer. Now with the sound trials, and we have the German SEMA trial, so it's an issue of discussion, and you know that the ASCO recommended back in 2019 omission in patients elder than 70. So what is important for us, what we think, I would not take an age cutoff, but what we would do is discuss, have a pre-treatment interdisciplinary discussion, because the sentinel node biopsy procedure is staging procedure, and it should tailor treatment decisions. So we should discuss with a radiation oncologist and a medical oncologist before surgery whether the result of sentinel node biopsy will have any implication of local, regional, or systemic treatment. So if not, there's no sense in doing a sentinel node biopsy.
Okay, thank you very much.
But I would not take age as in cutoff, because if you have a 70-year-old lady, we will treat her as a 60-year-old lady if she's in good health.
Okay, thank you very much, Professor. Eu gostaria de só fazer mais comentário.
I would like to make one more comment very briefly, which is I'd like to congratulate Professor Lilian Faroni, and really once again, as a surgeon, I do breast reconstruction, Her video is cutting. She's breaking off. Well, results are not always the same, one quadrant with another, considering re-irradiation. So these new studies that she showed makes us increasingly more sure that we can truly do a conservative reapproach, preferably doing partial re-irradiation, because it has shown that disease-free survival is similar in both groups, and especially know that the cosmetic results are better. So congratulations for your presentation, very good. I just wanted to leave aside my surgeon side. She broke up, sorry. Her video is gone. Yeah, I was off the air, but I just wanted to thank you all and congratulating you for this event. Thank you very much. Well, now moving on to what Lilian said, and Gabriel, do you have any remark about this panel of surgical de-escalation? Yeah, thank you very much, and congratulations to you, Enrique Lima, who have brilliantly organized this meeting. I followed a meeting of great quality. It is an honor to be here participating in this discussion. Professor Lilian as well. I would like to add to this discussion and ask Lilian, within the context of neoadjuvant therapy with partial radiotherapy, what is her opinion about this? And ask professors, we have some papers showing here potentially exciting results of initial results to do radiotherapy before surgery. Lilian, what is your opinion? And congratulations on your presentation. Well, thank you everyone. I agree with everything you said, Gabriel. This event is a huge success. I think that this is the future for us to try to increase the rate of complete pathological response. Of course, now we're getting a little bit away of what I said in my talk. I don't think there's any evidence today to think about neoadjuvants with radiotherapy in a case of relapse, but I think that in initial cases, thinking about the prognosis of these women is changed with a complete pathological response. I believe this is indeed the future. I think radiotherapy is increasingly gaining strength. There's a part of the world wants to remove radiotherapy for women over 65 years, but some other part of the world want to maybe not operate more than women with complete pathological response and only irradiate. So I think we really have to benefit from the side of the world that is supporting us. Thank you. Dr. Pedro, would you like to make your remarks or ask any questions? Yes, Gabriela, thank you very much. I congratulate you all for this event. Enrique, very good, high level of event. Well, I have some comments to make. I think that it is very clear for us, and we clinical oncologists, we see the prognostic role of the axilla, and it is truly an axillary residual disease will not have much impact on the outcomes of these patients. But I also have some comments on the SOUND trial. It is a study that started recruiting back in 2012, and this past decade we have huge progress in the adjuvant treatment in all settings, luminal patients, triple-negative patients, and also HER2-positive patients. And one of the comments I bring here, one of the observations is that maybe the tumor grade is important, so this has to be placed on the table. Dr. Kühn talks very well about this previous multidisciplinary discussion prior to surgical decision, fundamental to see whether or not, especially considering the new studies, luminal, Monarchie, and Natalie, that will enable us to include one more treatment in the adjuvant, being ribociclib or abemaciclib. So these are patients of lower risk, maybe negative axilla. Natalie, the inclusion is grade 2 or 3 with negative inclusion, KM above 20 or N1. So even patients with a small axillary tumoral load, Monarch are patients with higher risk, more than 4 lymph nodes that do not fit the sound settings, but patients from 1 to 2 lymph nodes that have grade 3. So these are patients we can impact. We don't have data on survival about these studies, only of survival free from progression. But in San Antonio this year, we'll have positive data. So then sound comes here. Maybe disturbing is a little bit, if you can say that. In also patients of BRC mutated, we can use laparide when we have positive lymph node. So I think that we have to assess the sound. It is a beautiful study, a very important study, but the data must be seen with a grain of salt so that we can better plan the treatment of these patients. I'd like to ask Dr. Giuliano, Dr. Kühn, and ask if you always have this multidisciplinary discussion. You consider the tumor grade, the presence of mutations in BRCA, and other factors in order to define to omit or not the sentinel node. Thank you.
Was it a question for me?
Pergunta para mim?
Yes, Dr. Kühn.
I can't hear you.
A pergunta foi para os dois, Dr. Kühn?
Yes, sir. Question to you and to
okay.
Dr. Giuliano.
Yes. So if this was a question, if we had regular conference before any treatment, yes, we do. And I think it's getting increasingly important. What is a bit unfortunate, as you said, is that by some new trials on luminal tumors, like the Monarch E trial, or the Natalie study, or the Olympia trial, these studies define the risk by the lymph node status. And this brings us in a little bit difficult situation, because on one hand, we want to de-escalate surgery, but we are a bit forced to escalate in order to define patients who might derive benefit from additional systemic treatment, like in the Natalie or like the Monarch E, where you need at least positive lymph nodes. But there's a broad consensus, at least in Germany, that we would say 3 or 4 positive lymph nodes. Could you hear me? Because I think the sound is not so bad, not so good here.
It's good again. Can you continue, please? It's okay.
Yeah, did you get me? I think this is a problem for most surgeons, that there's a tendency to escalate. We want to de-escalate our surgery, because of some new trial data that require a certain number of involved lymph nodes, some surgeon would rather go to escalate. And this is a discussion that we have, but we would not go for escalation just to make patients qualify for additional endocrine treatment, for example.
Ok, perfeito. Dr. Giuliano, qual a conduta que vocês têm tomado aí?
Okay, perfect. Dr. Giuliano, what is your treatment approach? Hello, Pedro. What I think is that, as a matter of fact, when we analyze the settings in which the sound study occurred, maybe it is the opposite of what was included in the studies for minocycline. Even though when we assess the number of patients that had a lot of axillary nodes, in the sound study, 0.2%, very rare to say that the negative axilla in the ultrasound shows a lot of disease in that axilla. Patients that would fit to use this inhibitor. So I believe that this discussion, multidisciplinary discussion, is fundamental, especially the sound. In its conclusions, it says that omitting the sentinel node can be done as long as it does not bother the adjuvant treatment. And to establish this, a tumor board is fundamental to talk with radiotherapy, the chemotherapist. So this is how I feel. And one thing that is very important is that, and I've been hearing this for a long time now, the sound was published
Até que todo mundo,
published a month ago, until everyone is, how can I say, oncologist and radiotherapist, until everyone is in the same sync, it is difficult to start doing it. We start selecting one case or another, discussing one case or another. So I, myself, today, I don't omit the sentinel node, even according to sound criteria. We have a study ongoing, the Venus study. So these patients now at Unicamp, they are included in clinical trials. But I believe that in a very short amount of time, with the discussions of these ideas and publication of other clinical trials that are ongoing right now, I believe the sentinel node is something that we will not do. And it is also important to have a good imaging study, right, Giuliano? We have ultrasound with a qualified radiologist that enables us to truly have information that today we are pulling radiology and pathology to be increasingly more specialized in the breast, right? Because this demand of planning is fundamental for the repercussion of everything the patient will do from then on. So interventionism that would do a core biopsy in the axilla when necessary to assess the lymph node. So we need this, especially in our settings here today, of reference centers being increasingly better trained to receive these patients, because we need this today. So I agree that we cannot be the first nor the last to take this step. We are moving, as studies are showing this path that I believe I don't see any other way around it. And that's it. I believe I agree with you. Anyone else would like to add anything? Dr. Kühn, Lilian, if Dr. Thompson is around, would you? Gabriel?
I saw a question.
Eu tenho uma pergunta, sim, se eu puder. Eu vi uma pergunta aqui no chat. Eu vi uma pergunta aqui no chat. Deixa eu ver.
Tem uma pergunta.
Eu estou com o chat só interno aberto aqui.
É uma pergunta sobre o
There is a question about the enzema. If patients with 5 centimeters are omitting the sentinel node biopsy, there's a similar study in Brazil, the Venus trial Dr. Giuliano talked about.
Can you hear me? I can answer to this. Can you hear me? For the enzema trial. So, can you hear me?
System.
No.
Yes.
Yes.
So I will write to the chat.
We can hear you.
Okay, that's fine. So there was a question regarding the enzema trial. So because you said it's brave to take tumors up to 5 centimeters, but in reality, in the enzema trial, the majority of patients have T1 tumors. So there are very few patients with T tumors. And in addition to that, there's a tradition in Germany for the neoadjuvant approach. So most patients with luminal B or triple negative, or all patients with triple negatives or HER2 positive will undergo neoadjuvant, and most patients with luminal B will undergo neoadjuvant. So there will only be a few patients with luminal A tumors where we may consider that we would consider to include in the enzema trial. But there are a few patients. The median tumor size is 2 centimeters.
Bom, queria agradecer a todos que participaram, os debatedores.
Well, I'd like to thank everyone who participated, the speakers, the moderators. I invite now the coordinator of the next panel, who's my dear and eternal professor, Dr. Enrique Lima Couto, Vice Chair of the Brazilian Society of Mastology, Minas Gerais coordinator of the Breast Image Department of our department, and member of the National Committee of Mastology, Director and Chair of the Rede Mama and Rede Masto Clinic. Thank you all. It was an excellent panel. Thank you very much.
Obrigada, gente.